Just a bit of introduction. Neuro-ophthalmology is, of course, the combination of the two disciplines, neurology and providers into this specialty can do so from either side. My TV resume. At the very, very beginning, the first research project that I ever did when I was a medical student, which was formative, right, for me becoming a neurologist, going into those, was in fact in the Parkinson's clinic. We did a project, a survey type, to ask patients about their experience when they received that diagnosis, what their experience was like, and sharing that with other people, kind of experience that they had. And so I've been managing Parkinson's patients way back in the beginning.
Can you just keep speaking up?
Yes.
Okay.
Okay. Maybe
Act like you're shouting.
keep shouting. Okay. I'll try to maintain that. Yeah. Okay. Yeah, that'd be good. If I turn it off to somebody, give me indication. And so I hope I can make this time worth your while to come and be here. What I am hoping to accomplish today is more or less replicate the conversation that I have in my office when I have patients with Parkinson's who come to me with vision issues. And so in that setting, my very first task is to make sure that there's not something else going on, right? Just because you have Parkinson's disease doesn't mean you're immune from any other neurologic or ocular condition. But if it is, in fact, vision changes related to Parkinson's, there are several things that are very typical. And I wanted to try to review that with you and explain some of what is happening, why it's happening, and although the recommendations that I have are fairly simple, I want to explain the why behind it, the anatomy and what's going on, why to do these things. And so anybody with Parkinson's disease understands that Parkinson's disease is a movement disorder that causes a decrease in movement, some slowness. And that's much more than just walking. It affects every facet of life and all the different types of movement, and that it will include the eyes. And so Parkinson's patients are known to have decreased facial expressions, okay? Not as much variability in different facial expressions, and you may have seen that, heard that. And of course, the eyes are included in there. And so we're going to talk about the ways that will impact vision. And specifically, I'm going to, right, we got power. Specifically, I'm going to go through the effect on the eyelids, the effect on eye movements, and that's going to break that down to the vertical eye movements and horizontal eye movements, which cause different symptoms and occur at different stages. And talk about some of the things that what I recommend for patients to do with that. And so the tip top of the list, the very first thing to talk about is blinking, the eyelids. Because of Parkinson's, sort of slowing things down, the eyelids will also work a little bit slower, a little bit weaker, and have reduced function. So in sort of normal physiology, there's a huge range as to how much we blink. Anywhere from 8 to 20 times per minute is considered to be a normal blink rate. And while I'm talking about this with you right now, I'm probably going to blink a ton because I'm thinking about it. And you probably will too. And so you think, okay, I can control my blinks, like that's something that I have voluntary control over. And while technically that's true, it's not really, right? So the rest of the 99% of my day, I am not going to be paying attention to what my eyes are doing. It has to happen automatically. And so unfortunately, you can't just consciously sort of extra blink your way out of this, okay? And so let's talk a little bit about what the blinks are for. Why do we have to blink? And then you can understand why it affects vision. So of course, the eyelids are there to protect your eyes, right? Something comes at me, I close my eyes, reflexively cover my eyes and protect them. But in addition to that, the eyelids serve as a support to the ocular surface because your eyes are out there, they're exposed. And so every time we blink, the eyelids serve like a little squeegee, just sort of clean the eye, give the eye a little bit of lubrication, a little bit of moisture, refresh it, right? And so just that over and over and over again throughout the day keeps the eyes healthy. And if there's a reduction in blinking, and normally, I said we blink anywhere from 8 to 20 times per minute. Everybody has some variation depending on what they're doing. And so if you're doing something visually attentive, so perhaps driving, watching anything, TV or something like that, reading, anything that's really sort of a visual task, the blinking will naturally slow down, you blink less. And so the symptoms might be a little bit more just when you need to use your eyes the most. And then Parkinson's, because of the slowness, tends to exacerbate that slowing down. And so patients with Parkinson's tend to blink a little bit less and develop more ocular surface disease. And ocular surface disease is definitely more complicated than this, but as an abbreviation, we kind of just call it dry eyes. Okay, but I want to go through the details of it because it's not simply dryness that causes the vision to change. It's more complicated than that. It's that nutritive and refreshing property that eyelids that's missing that causes issues. And so let's think about the corneal surface, the clear part of the eye, the cornea. Isn't that amazing? That's a living tissue made out of cells, and yet it's crystal clear. So when light hits that cornea, it can focus all those different light rays into a sharp and single image onto the retina, the back of the eye. How is that even possible? Like, why would that exist like that? There's a couple of unique features to that corneal tissue that make that possible. First of all, the cornea and the structures in the eye are probably the only tissue that I know of in the body that have no blood supply. Interesting. Of course it couldn't, right? Because blood isn't clear. If it was designed with blood, it wouldn't work, right? It wouldn't be clear. And so it can't have any blood supply. So how does the cornea possibly survive? How could it be alive if it doesn't have blood, right? Well, it can pick up oxygen right out of the air. But it gets the rest of the nutrients and the support that it needs from that tear film. And so the tear film is going to be really important. It's like a lifeline of the cornea. And the other thing about the cornea is just that it is a very, very highly structured cellular structure. So you look at it microscopically, the components are just extremely regular and structured. And that regularity gives it the clarity that it needs. And so what happens if we have dryness of the eyes, ocular surface disease? We don't have that support, the nutritive component of the tear film. And so the cornea starts to become hungry metabolically, and it starts to degenerate a little bit, or a lot. And as it does so, those highly regular structures start to become a little bit irregular and wavy. If you look at it in the microscope, it looks like it's cratered. It looks like it is very abnormal. And so what's going to happen then is the light rays are coming in, instead of focusing into a sharp and single image, those light rays are going to get more scattered. Okay, and so the symptom that people will experience with this are perhaps double vision, sort of splitting the image, a ghost ghosting of the image, or sort of shadowiness of the images. Certainly you can get like halos and streaks and glares and things like that because the light isn't going at a sharp image. And so that is the problem, and Parkinson's disease is a setup for this, just because with Parkinson's, we just don't blink as much, and the blinks that we do have just aren't as forceful, and so they don't give it as much oomph to it. And it's not just like one blink that you're missing and then you're in trouble, right? It's like this occurs over a long time with a sort of long exposure, and that's an important sort of concept to understand. When you think about what we're going to do to treat it, it's not going to turn it around right away, okay? And so it's going to take some time to improve to recover. So what can we do about it? We can't force ourselves to blink more, not much. And so we just have to optimize the tears that we have, okay? And so these are simple solutions. Improving the natural tears and supplementing with artificial tears is what is needed. And I'll explain how to do that in just a sec. But I just want to emphasize that it's not just the fact that it's dry and it just needs to get wet that's going to fix everything. Okay? It's the fact that it's kind of hungry, okay, and it's gotten damaged gradually over time. And it needs a nutritive, refreshing environment to be able to heal and work out the wrinkles and the kinks and develop that highly organized structure like it's supposed to be. And so it's sort of a slow recovery, but it can improve. And so if you ever have been told you have dry eyes or you have symptoms of dry eyes, I don't want to make it sound like this is serious, but there are consequences to this in terms of vision. And I'm going to come back to this again, talking about eyelids, that I think it's worth paying some mind to it and addressing it. And a couple of fairly simple, repetitive tasks can really make some difference. And so we want to improve the natural tears. And so to do that, I've got a couple of tips. But let's understand a little bit about what the tear film looks like first. Okay, we think of tears as just watery, end of story, right? Just a watery substance, and that's all there is to it, right? No, of course, it's more complicated than that. There are a couple of different layers to a healthy tear film. And so the very base layer is secreted directly out of the eyeball. And it's kind of like a mucousy layer. We don't know that because we get gunk in our eyes and we know there's mucus in there. That mucousy layer comes right out of the eyeball. And it sort of spreads across the eye and it serves as a surfactant. That's a spreader, right? It just spreads the tear film evenly so that it covers the whole eye. And then on top of that, there's going to be the watery layer. And that's what everybody thinks about when we talk about tears and running eyes and everything else. That's the watery component. And that comes out of the tear glands. And that's the nutritive support. So that's really important for the cornea. But then on top of that is the oily layer. And in terms of keeping things healthy, because it's the outermost layer, it's the top layer, I think of that as being the most important. And that comes out of different glands that are in eyelids. They're called meibomian glands. Meibomian glands are just specialized oily glands that are in the upper and lower lid, and their pores are right at the edge of the eyelid margin. So where the eyelashes are is basically where these pores empty out. And the oily layer is the sort of seal, right? So it goes on the top and like floats on the top, and it creates an evaporative barrier. It just kind of seals in all the rest of the layers that we've been discussing and keeps it all together. And so treating the oily layer is usually the best way to address this. And so that's done by lid hygiene, and which is two parts. So we want to get those oily glands working. And as things get dry, and just as we get older, those glands do tend to clog up. Okay, and so treating that with a lid scrub and warm compress gets those oils flowing and gets things working better. And so they make a solution for eye scrubs. You can buy these whiter eyelashes, or you can save yourself some money and buy, just use a cup of warm water and a couple drops of baby shampoo. Rather than get the no tears kind, it's going to work. And just get it a little bit sudsy and use a Q-tip to just wash your eyelashes. So the base of the eyelashes where the skin is, that's where those pores are. That's going to open up the pores, and then apply a hot wash rag. So just get that wash rag as hot as you can tolerate, don't hurt yourself, and put that over the eye. So scrub first, do the wash rag, the compress, and the wash opens the pores, and then the heat starts to melt the oils to get them flowing better. Okay, doing that morning and evening is a really good sort of maintenance. Call it eyelid hygiene or eye hygiene. It doesn't mean you don't have good hygiene if you're not doing it, but it's an extra step you can take to take extra good care of your eyes and improve your own natural tears. Okay, so that is sort of like basics, number one, first thing. And again, pretty easy to do, but it takes a lot of consistency, right? You just got to do it twice a day, every day. And then if we're talking about improving our natural tears, then obviously there's an artificial tear component to this as well. And so I do recommend supplementing the natural tears with artificial tears to give them extra lubrication, hydration. And so that's easily done. These are available over the counter. I just want to caution to get drops that are just as close to natural as possible, right? So unmedicated drops, and I like to recommend preservative-free tears, okay? Just to make it as close to what it ought to be as possible. And if you get the unmedicated preservative-free drops, you can do it as many times as you feel that you ought to. Okay, there's no limit on putting those drops in. As there is with the medicated drops, you don't want to be exposing your cornea to too much preservative and stuff like that. And so it's just a drop. It's only going to last a couple hours. It's not going to last you all day. So a minimum of 4 times a day. So if you do that, that is a great sort of basic regimen for taking care of ocular surface. And again, the first time you put the drops in, you shouldn't expect a whole lot of change. It takes time because it's got to heal because it was a chronic dryness that got into that situation. So it takes some time for it to become healthier again. But it's a living tissue, so it can heal. Okay, so that is my recommendation in terms of the eyelids and the dryness and ocular surfaces. The next thing on my list that comes up very frequently, well, we're going to talk about eye movements, but typically it is vertical eye movements that are affected earlier than horizontal eye movements in Parkinson's disease. There is a form of Parkinsonism that you may also be familiar with, PSP, progressive supranuclear palsy, in which the eye movement abnormalities are so prominent that they name the condition after the eyes. So the palsy that they're referring to is the eye palsy. That's not such a significant feature in Parkinson's disease, but all forms of Parkinsonism have some overlap, and they can have share some of the same symptoms. And so patients with Parkinson's do tend to have some slowing of their eye movements. And so the good thing about vertical eye movements is that when we look up or down, that's what I'm talking about, the eyes always move together. And so if they've gotten to be slow, they're still, yoked together. So they're still working unified. So they might be a little bit slow moving up or down, and that may take some additional time to do some tasks. May make some tasks a little bit harder, but they're still synced, and that is going to it's going to be different when we get to the horizontal eye movements. But for the vertical, there is one particular situation that comes up all the time, and it's pretty basic. And I just want to sort of get that one out. And that's the use of glasses. So Parkinson's disease is common in older individuals, and most older individuals also need to wear glasses. And typically, at an older age, it's also some sort of a bifocal type of a glasses. Meaning, you have to have a different prescription for near and distance. And to accomplish that, we put a different prescription in the top and the bottom of the glasses. And so you can see how if a patient has slowing of their vertical eye movements, that might actually impair their ability to use those, right? So if you think back, if those of you who use bifocals, particularly progressive lenses, okay? The multifocal lenses, so there's a distance prescription, and there's a near prescription, and it's a gradual gradation from the one to the other. And so it varies gradually. It's awesome because every single possible distance or depth of view that you would want is represented in those glasses, okay? But it also means that for every depth of view, there's exactly one spot that works, and the rest is off, and it's going to be some blurriness, okay? So anybody who has those will probably, many of you have, experienced when you first got the glasses like that. There's sort of like this warp effect. As you look at the world and you kind of look through them and you get really kind of like going from the near to the far and the blur coming in and out. And it kind of feels weird. And most people don't love their glasses that, that first when they get them. But you get used to them, right? And that is a training that your brain kind of gets better and better at using the glasses to look through the exact right spot for the task at hand. So up close, you gotta look down, far, you gotta look further away, and then it's everything in between. So if the eye movement starts to slow down, the vertical movements, you can see how that training that it's already automatically done with yourself starts to become less precise. And it can get to a place where patients are just not using their glasses appropriately. And I've had patients come into my office and say, I've got really blurry vision. And we do the eye chart, and I'm like, yeah, it really stinks. And then all I did is I picked the glasses up half an inch. I'm like, oh yeah, I can see 20/20 now. Because they just weren't able to sort of get the eye into the right position on their own. So what can you do about that? You still need glasses. And so it just depends. And then how bad is this bothering, right? How bad is it? Most people find that these progressive lenses or bifocals are just super convenient, right? And so it is sometimes a trade-off, and it's worth it just to have that. But if you're going to be doing a single task, like reading, okay, it makes a ton of sense to have a dedicated pair of glasses that are just for that. So it doesn't matter where you look, right? Because if it's reading glasses, then you can just look through the glasses at any place, and you have the correct depth. If driving is difficult for you, right? Having a dedicated pair of glasses that are just for driving will be helpful. Now, you still gonna have trouble with the dashboard. I get that. But sort of the main task of looking out and doing what you're trying to look at, maybe that's worth having a pair of glasses for that. Of course, the trade-off for this is that you gotta keep track of all these glasses. And it gets to be troubling. People like to wear their glasses, people that just lose their glasses all the time. So that's a trade-off, and I get that. But that's one of the potential solutions for this issue. As a compromise, I usually tell patients to look at just getting the more old-fashioned line bifocals. Line bifocals got just a chunk of glass that's distance and just a chunk of glass that's near. And so you still have the convenience of one pair of glasses, but it doesn't take as much precision, right? You just have to look through that part or that part to get it right. And so generally, patients who experience this, that's sort of a good compromise. But it's just glasses. You can try different things and sort of what works well for you. So that's oftentimes the biggest thing I see with the vertical eye movements. And that usually comes first if the eye movements are effective. Okay, not everybody has every symptom, right? As the condition of Parkinson's progresses, it does start to affect horizontal eye movements. And this actually gets to be more complicated because, of course, our eyes are side by side. And so with our eye movements here are much more complicated. And so depending on where I am looking, my eyes are constantly adjusting to the depth of view, okay? And this is the kind of thing that's so automatic that we just take it so for granted until it doesn't work. But think about this, everything you ever looked at in your life, your brain figured out where to point the eyes, how much muscular force it would take to turn the eyes in that direction, how much muscular force it would take to hold the eyes off center, and it sends the signal to the muscles, and it coordinates it so both of the eyes do exactly the same thing. It's actually really complicated just to look around, okay? But our brain usually does a really good job at it, and we just take it for granted. As the eye muscles do slow down horizontally, we start to lose the ability to refocus at the different depths of view. So when I look at something far away, my eyes spread apart. It's called divergence. When I look up close, my eyes have to point together. That's convergence. And that's where things start to go wrong. Because it's a little bit weak. The eyes don't bring it in enough. Right? And it usually starts with a near problem. So if things get too close, you'll start to get double vision. Now, to a certain extent, this is true for everybody, right? So I'm looking at my finger here, I see a single image, and I'm getting closer and closer and closer. So far, so good. But as I approach about here, it's a bit ridiculous. But as I get here, I can't pull that together anymore. And I see 2 fingers, okay? And you'll probably see something as well. But the issue is when that point of fixation starts to get slip a little further and further off to where you would actually have normal functioning vision, right? So I don't ever do anything up in front of my eyes like that. It's just not an important thing for me. But if it starts to get to where, your typical reading distance or, any kind of handiwork that you're doing, if it's within that range and your eyes aren't pulling it together anymore, then you're going to develop double vision, okay? The way to confirm that that's the kind of issue that's going on, very simple. You just cover each eye independently. So you're looking at that finger and cover it right eye, and my left eye sees A-OK. And then I cover my left eye, and my right eye sees A-OK. And then I just check them out. Both eyes are able to see fine. And it's together, it's the yoking of the 2 eyes that is not working. If I open the 2 eyes and now it's done. Okay? And so that's convergence insufficiency. As things go, it can progress to where looking far away also becomes interesting. Like across the room, way far away, the eyes don't quite spread out enough. And so patients will get to a place where there's like a little sweet zone, maybe like 10 feet away or whatever. Each patient might have their own unique place where things do work fine, but up close it's not great, and at a distance it's not great. Okay, so that's the problem. And in terms of the solution, I mean, I'll admit this one is a challenge. Okay, experiencing this double vision, but there's a couple of ideas. If it's not too bad, it hasn't been too much, and it's particularly if it's just near or if it's just distant, if it's just one or the other, then I oftentimes will recommend that patients give glasses a try that have prism lenses. Okay, so prisms, you probably know, they're able to bend light. And so if the eyes are out of alignment a little bit, the prism can make up the difference by bending light and bringing those images back into their proper alignment. And so if that is attempted, I have just a couple of cautions. I think it's a good idea. I think it's worth trying, but recognize that your eyeglass prescriber needs to have some really sort of specific instructions. What do you want to accomplish with this? Okay, because if I'm looking at my hand here and I'm looking at it here, we might not think that that's a big difference, but for this eye movement that I'm talking about, it does matter. Okay, every point along the way has a slightly different variation in terms of how much convergence is needed. Okay, and so you need to be sort of really specific about, like, I want to see things like this is what I hold my newspaper or tablet, probably, whatever it is. This is where I want to be able to see, and then have them try to measure the misalignment of the eyes and prescribe the appropriate prisms for that. But recognize that Parkinson's is a degenerative condition, right? So it does have progression. And so if you go in one day and get your eyes measured, they can perhaps even measure it perfectly. And by the time you get the glasses and you try them out, it may not actually be exactly what you need anymore. And it may not be what you want. So I usually recommend to my patients that it's worth giving it a try, just maybe one time to see if you like it. Okay? But if not, we were just talking about this. These glasses get to be kind of expensive. And going and getting it, and then another pair, and then having just a drawer full of useless glasses they spend a fortune on gets to be pretty frustrating. And so if you don't feel like you're making progress with prisms, I wouldn't just keep beating that. Okay? It's not for everybody. Some people can it works well, it's a great solution. But if it's not working, what can we do? My solution here is crude but effective. Yeah, if you've got double vision, because the two eyes aren't working together, you can always eliminate one eye, right? Now, it's not that crude. It's not, it's just cover it over, right? It doesn't have to be anything. I mean, there's a lot of different ways to accomplish that. And so I guess sometimes we think about like a pirate patch. Well, that'll do the job. But most people who are already wearing glasses, you can just use your glasses, put like a little piece of tape. And it doesn't take much, just a little blurry tape, like a Scotch tape. You can get medical tape that doesn't leave a residue, and put it over the lens on one eye. So whichever is your better seeing eye, cover the other one. And just block that extra view. You're already used to wearing glasses, so it'll feel very natural. The glasses allow a little bit of light to come in around the side, and you can see a little bit of that peripheral vision, so that still feels pretty normal as well. But it blocks the part where the two images overlap, and so you can see that single and sharp image. And you definitely don't need to do it at any point. You don't have to do it all the time, just whenever it's convenient for you. When you feel like your double vision is bothersome and you don't see more clearly, you can resort back to that to eliminate the second image. Okay. The last thing that I wanted to cover, I'm going to touch back on the eyelids, and it is this, that Parkinson's sometimes has some real surprises to it, as everybody knows. And so I told you how Parkinson's is all about slowing down and some of the speed and the strength of the movement, right? But sometimes it goes the other way, and the eyelids become too active. And so this is one of the complications of Parkinson's that we see that affects the eyes, called blepharospasm. Blepharospasm is too much eyelid closing. And so blepharospasm is a form of dystonia. And some of you may be familiar with dystonia. Dystonia does occur in various manifestations. I've had patients who the big toe sticks up, and patients with a sort of like twist in the neck or some facial movements or something that is uncontrolled muscle tone, dystonia. But in the eyelids, it's going to manifest with too much eye closure. Okay? So we said earlier that Parkinson's patients don't blink enough, and that's where they get into trouble. So now, how does that fit together? It turns out that there's something about Parkinson's disease that is a unique risk factor for this. And so it is felt to be that something about the brain chemistry in Parkinson's with the lack of dopamine, okay, is a setup for developing a dystonia. And also, the chronic dryness of the eyes that may have preceded this situation is also a setup for dystonia. And so let me think through that. So if you have decreased blinking, the eyes get dry, the cornea is sensing that it's not healthy, and it's sending these signals to the brain like, hey, you should blink more, you should water more, give me some more support. But because of Parkinson's, it just doesn't do it as much, okay? But those signals are sort of constantly flooding the brain is sort of constantly bombarded with that. And then in that low dopamine environment, we call it a two-hit theory. The first is the dryness, and the second thing is just the Parkinson's. But in that low dopamine environment, there's something that goes awry, and a switch just gets flipped. And instead of not blinking, then that blink reflex starts to turn on, and it goes too strong. And patients can get to the place where they blink in really an uncontrolled manner. And it can get to the point where they can't really even open their eyes because the urge to blink it is so overpowering. And that's when we would call it blepharospasm. And so to test my patients with Parkinson's for the risk of this, and many have it, so I don't want to put you too alarmed, but I want to give you some to try to avoid this. I do a test called the glabellar reflex, and just touching the face right between the eyes. You may have noticed when I did that, even to myself, I blinked the first time when I touched my face. Okay? But then not the second or third or any further time. Because you get the idea, like, okay, I'm not going to touch the eyes are safe right now, I don't need to blink. and the natural blink reflex just turns off, okay? In patients who have this setup where they're at risk for blepharospasm, they will just keep blinking every time I touch. And we can just keep going, but of course you get the idea after a couple of blinks. And it looks like their blink reflex is cranking up, and that's not in and of itself blepharospasm, but it is sort of an indication that they would be at risk for developing. Okay. We already know that there's no cure for Parkinson's disease, and so that brain chemistry is in the mix, and that's going to be like that. But we talked about the dryness before, right? That's why I spent so much time, actually, in part, because treating the dryness can help eliminate that other hit. It's two hits, right? Signaling for the dryness, and then the brain chemistry. And by keeping the eyes well hydrated, then it reduces the chances of developing that blepharospasm down the road. So I think that that's a good thing to know about, not to be worried or scared about it, but just to be prepared and here's something that you can do to actually prevent and potentially avoid that. And if you do have blepharospasm, even then treating the dry is still worthwhile because it can still help to minimize how strong that goes. Okay, so I have given a lot of information, and some are very, very specific tips. Like, wait, did he say, was it 3 times a day or was it 4 times a day? Like, what did he recommend? And so I actually have a website that I created. This is actually the prompting of Dr. Cloud, who just stopped by one time and said, could you put together something for me, like just a worksheet or something for Parkinson's patients, just to give them to know what to expect and what the visual symptoms would be like. And so I had at the same time sort of working through my mind, like, how can I teach my patients better? And I had this idea of creating a blog. So I did. I created a blog. Looks like we went to leave here, so it's coming back. I'm gonna log in. And I put it down. And so this was the very first blog post that I did. And I've done many others that have nothing to do with Parkinson's since then. But you are all welcome to utilize it. So just to review all the same, more or less, the same things that I've talked about here today. So it's called Neuro-Op Shop Talk. And check it out. You can find it, just Google that. You can find this, and just go back to the original post, the very first one, vision symptoms in Parkinson's disease. So I have, is it another 10 minutes?
Yeah.
Okay, so I've got some time for some questions. We can certainly review any of the stuff that we talked about, and I am happy to delve into some other questions that you have. It's obviously not everything.
Does Restasis help with dry eye?
Yes. So I didn't go into it completely. The idea behind Restasis is that it's another drop, and anytime we're putting medication drops in the eye, I just want to be aware that the surface of the eye has to have a burden to deal with that medication, right? Because it has to metabolize that, and it's not really good at it. So there's a bit of a trade-off with medicated eye drops. But if there is significant inflammation, we talked about those meibomian glands getting gummed up, and they oftentimes do. And when they do, they usually get inflamed, right? And so we will call that blepharitis. If the patient has actual inflammation, blepharitis, the Restasis and some other options that are similar have a anti-inflammatory property to them, and they can help to reduce the inflammation and help get those meibomian glands ungummed up, and can improve the whole ocular surface. We just have to try.
What could you do when the patient cannot keep his eyes open?
Because of the blepharospasm?
Well, I mean,
Yeah.
he can't blink and he can't keep his eyes open.
Okay, so my guess is that at this point, the eye movements have slowed down so much, they've lost a lot of blinking, and then develop the blepharospasm to the point where it's not really what you would call blinking anymore. It's just eye closure. Yeah. And there is it's complicated, it's neurologic. So when I say blepharospasm, and they call it eye blinking, I just kind of simplify it. Every time a muscle moves, in neurologic action, there is a relaxation of the opposing muscle. So the easy example is when I pull my arm, my biceps has to contract to do so. But at the same time, my triceps is going to relax to allow that movement. So at any point, there's a little bit of tone both ways. And so we sort of tighten it up. In the eyelids, there's both eye opening muscles and eye closing muscles. So every time I see blinking, we're just all thinking about eye closing muscles, right? But as you blink, your eye opening muscles also relax, right? And so there's a very specific term that we can get picky about it and call it blepharocholysis. The blepharospasm means too much contraction of those eye closures, but blepharocholysis is a weakening of the eye openers, okay? And so that is, that's a problem. And the two go together. It's like just two sides of the coin, right? They always sort of work together. But that blepharocholysis can be particularly problematic. For the eye closure, if that's too significant, we can use Botox, botulinum toxin, which is a muscle relaxer, and inject it directly into the location around the eyes that do that, relax those muscles that are closing the eye. But relaxing the eye closing muscle isn't going to strengthen the eye opening muscles. And I recognize that. Sometimes we still do that because oftentimes it's a combination, right? There's the eye closing and lack of eye opening. So we still do the Botox because we can reduce the eye closing that helps the eyes to open maybe a little bit. But if the eyes really won't open at all, then we have to give them a support. And I really start getting nervous about this. Okay, so I'm going to throw this out there and tell you, don't actually do this unless you're being supervised. But something to hold the eye open is essentially what you need, right? And I have had patients who will tape their eyes up, and patients who have glasses made, they call them an eyelid crutch, a ptosis crutch, where it's just got a little extra arm that reaches up to the eyelids, it just helps pull them back. The reason I worry about that is that remember the dryness was the problem that kind of triggered all this in the beginning. So there's got to be some background dryness in here, and we're going to take the eyes open now. Like, whoa, they're going to get really dry. So you got to be really good about doing that. If the patient is not, that great at attending to their own needs and then needing some additional support, it's not the best person to just take their eyelids open and walk away. And then let me also address putting in drops and stuff like that. Sometimes patients can lose some of their fine motor dexterity. Putting in drops is significant, right? So be careful with that. If you have somebody that can help support you, that might be necessary. But when you put in an eye drop, don't need to put it on your eye. Hold the lower lid down, tilt the head back. Just create that little cul-de-sac in there and drop it in there. And that way, if you miss and you touch your eyelid, you'll be fine. I don't want you poking yourself in the eye with the eye drops. So just safe way to do it.
When you said you got tears at the drugstore, unmedicated, what was that actually being done?
And preservative free.
Preservative free.
Yeah, that's as natural as you can kind of replicate.
I have cataract surgery scheduled for the time. Could I not do that?
So just because of cataract surgery, just because a patient has Parkinson's and has these other issues, doesn't make them immune to all the other stuff that happens. It's particularly just as we get older, the lenses get cloudy, and that's what cataract is. So, no, I mean, you still need to address that, okay? And you can talk to your doctor about whether you have dryness, but I can just guess because of talking about Parkinson's that it's a good chance you have some dryness. But more than other patients, you want to be really careful about whatever the recommendations they give you, so they're covering the eye, shielding the eye, the drops, things like that, and just using artificial tears that we talked about, plus the good lid hygiene, taking care of your eyes. Try to get to go a little extra step than what other people do. Over here.
Yeah, two questions.
Are there any oral medications that can mitigate some of these issues? And conversely, are there some oral medications that cause these issues?
I am glad you brought that up. So the first question is not directly, there's no medications that are designed for the eye, such as the Parkinson's or these things in general. So it's drops, and then of course just treating the Parkinson's, right? So if somebody's in their off state, they're gonna have more dryness than when they're on. Okay, that's the issue. But Parkinson's patients do tend to have a long list of medications. And dryness is definitely a side effect of polypharmacy. So the more medication you take, the more likely that you're gonna get some dryness effects. And so you can kind of go through your med list and see what, if there's anything particularly offensive on the list there that would cause dryness. For example, some of the medications, if there's like urinary symptoms and patients take medications for that, I think that's pretty sort of causing dryness. Things like that can be exacerbating the already what is, dryness just from the movement disorder. Let's go to the back.
Does dyskinesia affect the eye?
I've never heard that it does, and I'm not sure. I don't believe it affects eye movements. I haven't looked at that though. I don't know. But I do know, like I was saying before, the off state affects some of these things. And so dyskinesia is more of a phenomenon of the on state, which is, I mean, it's pathologic in some ways, but not for the eyes that I know of. All right, let's go in the back right here.
If it's time for you to go for your annual eye exam, should you go to someone like you, a neuro-ophthalmologist, or just keep on with your regular doctor if you don't appear to have symptoms?
Yeah, I think that for sure you can work with a regular eye doctor. So part of it is practicality. There's like a couple of neuro-ophthalmologists in the state of Virginia, right? And Parkinson's disease is a small fraction of the patients that we see. And so I will oftentimes see patients in consultation and kind of explain some of these things, but then they'll still receive their regular eye care from the regular eye. In fact, as a neurologist, I don't actually do some of the regular eye stuff. I don't actually prescribe glasses. It's not within my scope. I don't have that privilege to do so. So you still need a regular eye doctor.
Still different question. With Parkinson's, are you more prone to retinal tear?
Parkinson's related retinal tears. I don't think that there's any connection to that, although I will say that I know that there is a very, very slight retinal thinning that occurs in Parkinson's disease. Parkinson's is a neurodegenerative condition, and retinal tissue is actually neurotissue. And so there are actually dopamine secreting amacrine cells in the retina. And so they do tend to be deficient in Parkinson's patients. But the difference is so very subtle that I don't think it has any clinical significance. And I don't think that you can even distinguish it. Like, you can't just look at an eye and say, oh, this is a patient with Parkinson's. In a population, you can average them all together and you can see the differences. But in an individual person, there's more normal person-to-person variability than with a Parkinson's attack.
Patients with really severe tremor who really struggle with drops, is it safe to allow them to use a lubricant like Lacrolube long-term in lieu of drops to manage their dry eyes, or is that really meant only for short-term use?
The lubricant.
Repeat the question.
So the question is whether patients should use lubricant, ocular lubricating ointment instead of eye drops, particularly if they're at risk of injuring themselves with that. There's other things that patients can do for that particular issue. If you look for it, they have like an ocular like cup where it goes over the eye and it gives you a much bigger target funnel where you can put the eye drops in and have a bigger target to hit the eye, hit it safely. If I have patients who have symptoms of dryness, first thing upon awakening, I usually recommend the ocular lubricating ointment. Very thick. It's almost like putting Vaseline in their eye. Okay. And the reason is because they're going to be asleep through the night and they're not using their vision anyway. So why not goop it up with the thickest richest, stuff that there is, okay? But during the daytime, it's so goopy, I mean, it's like Vaseline in your eye. It's gonna significantly affect your vision, and it's just not very good. And so I typically recommend artificial tears for daytime, and if needed, in particular, some people don't actually close their eyes when they're sleeping. You can have somebody take a peek at you during the night and see, but if your eyes feel dry when you're waking up in the morning, then you might need something extra thick for that. As an in-between option, that you make gel drops. Okay, so it's a little bit thicker than regular drops, and it's a little bit goopier than regular drops. And so that is another option too.
And that gadget that you mentioned that helps, is that available over the counter, like at any pharmacy, or do you have to get that from an eye doctor?
No, I'm pretty sure, I've only ever looked at it online, and it was pretty easy to find. That's great.
What I was wondering is, when you were saying sometimes just get reading glasses, so when regular reading and then you look away and everything's already blurry, but you can look back and read your thoughts and you look up and things are all blurry. Is that what you would say, maybe you think that with reading glasses is fine?
So I think your question is, somebody who's not using reading glasses can read okay, but then after they've been reading, they look away and their eyes got used to reading so much that they can't see the distance. You know what you're saying? So there's some individuals who are just very nearsighted, and it's almost kind of like they got built-in reading glasses because they're so nearsighted that they don't actually need the reading glasses. And so that's a unique situation where they can just sort of use their nearsightedness as their reading glasses, and then they'll need regular glasses for distance. But it is true that if you have your natural lens, there are muscles that are trying to focus the eyes. And if you focus them by a long time, just reading for a while, they get kind of used to being focused and they have a hard of relaxing at a distance. So wearing the reading glasses to supplement that can help to look away. That tends to be at probably between the 40s and 50s where people first start using reading glasses. Once people get too far along, the lens just gets so stiff that the muscles don't do that much anymore. And that's usually about the same time when you're talking about cataract surgery, because that's when the lens is so stiff that it's become cloudy. That's a cataract. These are great questions.
Would Parkinson's be more apt to get those mites?
Eyelash mites. So that is one of the reasons for getting blepharitis, that's inflammation of the eyelash mites. I don't know why Parkinson's would be increased risk for that, but it would certainly compound it. Yes, and there's treatments for that too.
Dr. Haines, I know you've got to wrap it up.
Yeah, and so we want to get Dr. Cloud some time.
I can't thank you enough for being here. I know you've got to get off to another meeting. So I think everybody jump on this blog for some additional answers and make an appointment potentially. So thank you.
Okay, thank you.
Yeah.
Thank you.
While I pull this up, why don't we start with a quick poll? So first of all, how many people in the room will go on record and admit to having aches and pains on a regular basis? So that's almost everybody. Me too. Already. So. All right. Okay, everybody can hear me, everybody can see?
Move your mic a little bit.
How's that? Better? All right, there we go. Okay, so we're talking about pain in Parkinson's disease. So as I'm sure you all know, pain is a part of being alive for all of us. Whether you have Parkinson's disease or not, as we get older, we get more aches and pains. And it is just part of being alive. But pain is also extremely common in folks with Parkinson's disease. And when people have done surveys of people with Parkinson's versus age-matched people without Parkinson's, pain is certainly much more prevalent in people who are living with Parkinson's disease. So we're going to talk all about the different types of pain that we see in Parkinson's disease and some of the underlying causes, and what you can do if any of these are relevant to you or someone that you know. And please feel free to, raise your hand along the way, interrupt. You don't have to hold questions until the end. We can make this a bit more interactive if that's easier for folks. So, pain can actually be the initial symptom of Parkinson's disease. That's actually true in about 5% of cases. And in my own practice, I would say this is most likely to be true in the young onset population. I don't know if we have any young onset folks in the audience. I see a hand up in the back, but the young onset patients tend to present differently than the typical onset. So young onset patients tend to present with a problem called dystonia, where they get involuntary muscle contractions on one side of the body, and those muscle spasms and contractions can be uncomfortable. And so oftentimes the first symptom is pain on one side of the body, and it may be centered around the shoulder or another large joint. So this is often confused for an orthopedic problem. And so sometimes the Parkinson's disease actually presents to an orthopedist. And if you see a really astute, good orthopedist, they're going to realize that, your joint appears to be fine, but there's these subtle neurological signs in that limb, and they're going to refer you to someone like me. And that's often the case. It's also possible that the pain may just go along with other early motor features. And so, you may have tremor or stiffness or slowness on one side of the body as your, symptoms manifest themselves, and you may have pain associated with that. And of course, the pain tends to be on the side that's most affected by the Parkinson's disease. And then as the Parkinson's spreads and involves the other side, the pain may as well. So, as I mentioned, this is often confused for an orthopedic problem, especially early on before the Parkinson's is clearly diagnosed. And so some of the common presenting and early presentations are frozen shoulder, or someone presenting with just chronic shoulder pain as a first manifestation of their PD, or a shoulder and arm, just chronic pain syndrome due to stiffness from early Parkinson's disease. So then when we move beyond, new Parkinson's disease, undiagnosed or newly diagnosed, and we look at people who are living with Parkinson's disease that's, in, all stages of the disease, more than 60% are living with what we call chronic pain. So that's pain that's been present for more than 3 months. And so when we look at what the different types of pain are that are present, there's really 4 main categories. There are others that are very, very rare, but there's really 4 major ones. And so those are broken down into what we call musculoskeletal pain. So that's pain that comes from muscles and bones. And then there's nerve pain or neuropathic pain, which, as you might imagine, comes from nerves. And then there's pain from dystonia, which is the pain that comes from that problem that we talked about, which is abnormal involuntary muscle spasms and movement, which can cause tightness of the muscles and pain in the involved muscles. And then there's something called central pain, which is the most rare of these four types. Musculoskeletal is the most common by far, and central is the most rare. And we're gonna talk about each one of these individually, but central is the most difficult to diagnose because it's a bit bizarre in the way that it can present, and it doesn't make oftentimes a whole lot of sense to the individual or to the doctor who's trying to help the person figure out what's going on. And it can be very difficult to treat. And so we're gonna go through and talk about each one of these individually. But first of all, let's just talk a little bit about why people with Parkinson's may experience pain more than people of a similar age who do not have Parkinson's disease. This is not a topic that's well understood at all. This is an area where a lot more work is really needed to fully understand what's going on. But from the small amount of research that's been done, there's a few things that we know and a few theories that we have. So first of all, we know that somehow the pain in PD is tied into the dopamine dysfunction that occurs. And the way that we know that is oftentimes pain in Parkinson's disease responds very well to just optimizing dopamine medications. And so if someone's complaining of pain, oftentimes, regardless of what kind of pain it is, of those four that we just talked about, the first thing we do is make sure that their Parkinson's disease medicines, their dopamine medicines are optimized. And that will often solve the problem as a first step. So somehow the dopamine circuits are tied into the increase in the experience of pain in Parkinson's disease. There also seems to be some sort of dysfunction in the actual pain pathways that lead to a lowered threshold for pain perception. So individuals with Parkinson's disease may experience pain more intensely and at a lower threshold than individuals who don't have Parkinson's disease. And again, for reasons that we don't entirely understand yet, but there are people who are looking into this on the research side. And then there are certainly higher rates of musculoskeletal complications that are a direct result of the Parkinson's disease motor symptoms. So as you might imagine, if you're having dyskinesia all day, or you're having tremor all day, or your posture is changing because of Parkinson's disease, that's going to put excessive wear and tear on your joints that wouldn't be there otherwise. And so you're more likely to develop osteoarthritis or get a pinched nerve in your back, from poor posture, or any number of other issues. And so there are these secondary problems that can arise as a result of the motor symptoms of the disease. And then there's also evidence from animal models that there are alterations in inflammatory signaling, that there is sort of a pro-inflammatory state that's present in individuals with Parkinson's disease, and that impacts our pain perception and pain experience. And so there is a very real connection here between pain and Parkinson's disease. Okay, so we talked a little bit about the causes. Now let's talk about the effects. So if you're living with chronic pain, what impact might that have on you? Well, for starters, we know, again, from multiple studies, that people with chronic pain are more likely to have depression, anxiety, other mood issues. They're also less likely to exercise. And I hear this quite literally every week in my clinic. I see people who sustain, an injury, maybe they fall and, have a soft tissue injury and they're in pain and they have to stop exercising for a few weeks while it heals. Well, in PD, that's a problem because exercise is such an important part of maintaining function, and even just a few weeks of being laid up in bed and not being able to move can lead to a pretty significant setback. And then, there's also a reduced participation in daily life. If you're in pain, you don't want to go out and be around people and do things, And so then it creates this cycle of isolation, which reduces quality of life. And then there's this cycle of decline from reduced exercise, and then that leads to more depression, and then, it's just this vicious cycle. And so pain can have extremely negative consequences if it's not aggressively addressed and managed. So, if you have an ache or a pain and you have Parkinson's, how do you know if pain is related to your Parkinson's or if it's just a random ache or pain that has nothing to do with your Parkinson's? So it can be really difficult to figure that out, even for your neurologist or for your physician, it can be really difficult to figure that out. But a few things to think about as you're trying to get to the bottom of that question. So ask yourself, does the pain correlate with other Parkinson's symptoms? So when I'm at my most stiff or slow or shaky, does the pain seem worse at that time? And is it better when I'm really on my meds and my meds are working at their best? If there's a clear correlation there, then I would say it's possible, and very likely, then that the pain is in some way connected to your PD. The other thing is, did the pain start right after your diagnosis or right after your Parkinson's symptoms started? Is it associated with dyskinesia on the days that your medication is working really well and you're experiencing a lot of medication-induced, involuntary movements? Is that when you notice the pain the most? That's another sign that it's tied into your PD or the treatment of your PD. And does it improve when you take your medications? So if you answer yes to any of those questions, there's a good chance it's tied in to your PD. And if the answer to all of those questions is no, then it's probably not, although it still could be. And so you really have to kind of talk this through with your doctor. So when you go to talk this through with your primary care doctor or your neurologist, you're going to want to have a good description of the pain. And so this is the cheat sheet that I would give you. And I would say, think about all of these things and try to jot down some notes before you go to that doctor's appointment or before you type up that message to send them in the patient portal, because these are all the things they're going to need to know before they can try to help you figure out what's going on. So let's just say, for example, the pain is in your back, and we're going to go through this checklist. So you don't want to message them and just say, I have back pain. That's not enough information for them to try to figure out what's going on or whether it's related to your PD or not. So the things that you want to think about, what makes it better and what makes it worse? So you might say, my back hurts when I am laying flat in my bed at night, and it gets better after I get up and start moving around. And then you want to describe the pain qualities. So descriptive words that explain what it feels like. Is it dull and achy? Is it sharp and stabbing? Is it like an electrical shock-like sensation? Just do your best. And I know that can be really hard. It's hard for me too when I get asked to describe my own pain, but try to put words to what you're feeling and to the sensations as best you can. And then does it radiate to other body parts? If you're having back pain, does it shoot down one leg, or does it stay right there in the back, in that one area? And then how severe is it? You don't have to be super specific. You don't have to put it on a 1 out of 10 scale, but is it mild? Is it moderate? Is it severe? And then that screener I gave you a moment ago about, is it related to your Parkinson's disease medications and other symptoms, is also extremely important. So I would try to think through all those things before you go to your doctor to talk about it, because that's all the stuff that they're going to need to know. And oftentimes, if you haven't thought through all of those things, it's a more challenging conversation. Okay, so let's talk about each of those different types of pain. For those of you that are taking pictures, I'm happy to share my slides. If you want a copy of my slides, I'll share them. So musculoskeletal pain, yes.
Yes, thank you. We call it migration of symptoms, meaning that, today, arm could be hurting, and it would last for a few days and then it'll go away. And then something else would hurt. And then a few weeks later, the pain in the arm comes back. Does that sound related to Parkinson's?
Possibly, especially if there's a theme. So if there's a few hotspots that you're rotating between, you know, and that seem to be cycling between, then I would say absolutely. And I would try to track, you know, the pattern and, you know, see if there's any, you know, any patterns that you can identify, like, oh, every other week when we go to physical therapy, that's when this hurts. You know, see if you can identify any kind of exacerbating or alleviating factors to those migrating patterns.
Thank you.
Okay, so musculoskeletal pain. So again, this one is by far the most common, both in the general population and in the Parkinson's population. So this is any kind of pain coming from bones and muscles and soft tissue. So the experience of this is going to be like aching, pain, cramping, muscles might be tender to the touch or sore. Joint pain also falls into this category. And you may have reduced joint mobility with this. And then changes in posture as well. The most common sites in the PD population for musculoskeletal pain, but also in the general population, happen to be the lower limb and the low back, because we get wear and tear arthritis that impacts our spine, particularly the low back. And then as we age from wear and tear, those big joints in our legs, the knees and the hips tend to go. And so those are the most common sites. And then in PD, the next most common site after the back and the lower limbs is the neck and the shoulders, as you see depicted in this picture. So, you know, when we see someone with musculoskeletal pain, we go through all of those questions we talked about earlier. We try to figure out if it's related to the PD or not. Oftentimes it's not, because again, things just happen, you know, with age. And so if we convince ourselves that it's really not PD related, or if it's a secondary complication from the PD, like someone maybe just has bad knee arthritis that's maybe been aggravated by their PD, then, you know, the answer is to refer them to an orthopedist who can help them with their knee. And of course, we do everything we can in neurology to just optimize the Parkinson's disease management so that we're not aggravating it any more than necessary. In terms of what to do if there's not a surgical intervention that's needed, like a joint replacement, then the management of most musculoskeletal pain is going to involve conservative treatment with things like physical therapy, maybe occupational therapy if it's an upper limb that's involved, non-steroidal anti-inflammatory medications like ibuprofen, and there are a whole slew of others, like Clopinac is another commonly used one, are the mainstay of oral medications. But there's also topical non-steroidal medications like Voltaren gel, like Clopinac gel, which can be very helpful. And then we don't do that as neurologists typically, but our colleagues in orthopedics and PM&R can do steroid injections for, you know, pain in joints and in the spine and, you know, other areas for tendonitis and things like that. So oftentimes musculoskeletal pain can be managed with steroid injections. And then of course, we mentioned surgery if it's applicable, if you need a joint replacement or, you know, spine surgery like a fusion or something like that. But musculoskeletal pain is far and away the most common. Any questions about musculoskeletal pain before we move on?
I had a question about shoulder impingement. You mentioned ibuprofen might be beneficial, and oftentimes that's due to inflammation in the shoulder. Should a patient kind of self-diagnose and maybe try that? And should they also possibly consider limiting their dose of carbidopa-levodopa? What you usually do?
Yeah, you can try it. If you think you have the shoulder impingement syndrome, those are super easy to diagnose, and treat. And oftentimes, treatment leads to immediate relief if you get the right diagnosis and the right treatment. So rather than trying to self-diagnose, if you really think that's what you have, you probably ought to see an orthopedist, a shoulder specialist. Because the diagnosis can be made very easily in clinic with just a good exam. And then they will tell you what to avoid, you know, with your exercises to not make it worse, what to do to make it better. They can do a quick injection to get you immediate relief, put you on some non-steroidals for a couple of weeks and send you to PT. And it will often take care of it very quickly.
Thank you.
Yeah, and if you know the name of a good shoulder person, I have one, so let me know. Yes.
What's your opinion on chiropractic service?
Yeah, I think if you have a good, I don't have one in particular that I have forged a relationship with, that I have a good working relationship with. I am not opposed to chiropractors. And I have a lot of patients who seek chiropractic care. I don't have a problem with it. I think that can be very helpful to you. So I think if you have a chiropractor or know one, or you know, have a relationship with one, seeking help from a chiropractor, particularly for managing musculoskeletal pain, can be extremely helpful.
Curious, when people are diagnosed with fibromyalgia, does this have anything to do with that? It seems like the symptoms are really close.
Yeah, so fibromyalgia is often treated with, we're going to talk in a minute about neuropathic pain medications, but fibromyalgia is interesting because the mainstay of treatments for fibromyalgia are actually the medications for neuropathic pain.
Okay.
So fibromyalgia is a little bit more complicated. It's probably a bit more of a neurological condition than it is a muscle and bone condition. Even though people with fibromyalgia have a lot of muscle and bone pain, the root of the disease is probably more of a neurological disease. But it's one of those diseases that, yeah, I feel sorry for fibromyalgia patients because I think they feel they feel probably homeless in medical land because it doesn't cleanly fit in neurology or rheumatology or orthopedics. And nobody really owns that disease.
Right.
I think it's because we don't understand it well enough. And so everybody kind of manages it poorly, for the most part. But when my sense is it's probably more neuropathic than musculoskeletal.
So people with Parkinson's can get fibromyalgia?
Oh, absolutely. Just because you have Parkinson's doesn't mean you can't get fibromyalgia.
Okay.
But it does, as far as I know, there's no data to suggest that you're more likely to get fibromyalgia just because you have Parkinson's. Okay. Neuropathic pain. So neuropathic pain feels very different, totally different from musculoskeletal pain. So this is your pain that is going to be described with words like burning, stabbing, tingling, pins and needles, numbness. It's very different from the soreness, the aching kind of pain that you get from musculoskeletal pain. Oftentimes people will say, I feel like lightning like jolts, you know, from neuropathic pain. That's a common one that I hear. And so this is pain that comes from nerves, and so it's often in the distribution of a single nerve root, which is often a clue that it's neuropathic pain. So for people with low back problems, you know, they will often describe neuropathic pain that shoots down the leg in the distribution of one nerve root. So neuropathic pain has multiple causes. The cause needs to be identified. Because if you have, for example, neuropathy, which shouldn't be happening in someone with Parkinson's disease, Parkinson's itself does not cause neuropathy. So if you're having neuropathic pain, we need to know why you're having it. we need to work up, we need to understand it, we need to make sure that there's not another medical condition that's causing it. But once we understand it and we know what's causing it, then, the management is, essentially medications. If it's not a treatable, curable cause. So if it's your back and you have a pinched nerve and it's something that can be fixed surgically, then that can just be taken care of and hopefully you're done. But if, on the other hand, let's say it's a neuropathy because you have diabetes and the diabetes has caused irreversible nerve damage, and now you have this permanent neuropathy from diabetes, that's not going to go away. And so we just have to manage the neuropathic pain as best we can with medications. And so, unfortunately, the treatment of chronic neuropathic pain often means that you just have to take medications. Because there's not a lot else that we can do for neuropathic pain. And I've listed the main categories of medications that we use for neuropathic pain. There's the tricyclic antidepressants like nortriptyline and amitriptyline. And then there's medications like gabapentin or pregabalin. And then there's seizure drugs like carbamazepine, which work quite well for neuropathic pain. So oral medications are the mainstay. If it's mild, we can sometimes get away with topical medications like capsaicin cream, if it's a small area of your body and it's mild. But most of the time for severe neuropathic pain or for neuropathic pain that's a big body region, we just have to take those. Sometimes PT and OT can help. Again, if it's a pinched nerve in your back, PT might be able to address that. But again, if it's a more diffuse neuropathy, drugs are sort of sometimes all we're left with. So the devil is in the details with neuropathic pain. You need to work out, we need to know where it's coming from, you need to rule out treatable causes, fix them if they're identified, and once we understand it, then we can come up with the best and least toxic treatment plan. Questions about neuropathic pain?
Restless legs. That considered under neuropathic?
That is an entity unto itself. It's not really considered and this is really where neurologists get annoying. So the restless legs is considered a sensory syndrome, not a pain syndrome, which is obnoxious because if you talk to anybody with restless legs, they're going to tell you it hurts, right? But akathisia and restless legs are categorized differently than pain because some neurologists somewhere along the way decided to categorize them that way, right? And pathophysiologically, they're a little different and they're treated differently. They're treated with dopamine and other types of medication. So we don't typically think about them this way, but they do hurt.
Could the medications for some of these neuropathic issues like CRPS and RSD and Raynaud's, could that medication impact somebody that has Parkinson's? Could that medication actually impair the absorption or cause a different effect?
On the Parkinson's medications, not typically. Other way around is usually more of a concern. So the Parkinson's medications impact the rate of motility of the GI tract negatively. And so they tend to impact the absorption of other medications more so than it is the other way around. But it doesn't tend to be enough of an issue that you can't co-administer them. You just have to be mindful that there might be a little bit of tug of war going on and maybe dose adjust or separate the timings, to compensate for that and just be a little more mindful.
I think it's more sensory. But what a mean often, and unless we work out, I'll take a film off the phone. And things tight. Do you run to the side, do you do the hot?
So that's perfect segue into my next slide. So what she said was, in the evenings when her medication wears off, she gets this sensation that everything, all her muscles get tight and it's uncomfortable, and she also has a little claustrophobic. And that's actually a perfect segue into this next slide. But before we get there, let me grab this question back.
What question, would sciatica pain be related?
Yes, so sciatica pain is technically a pinched nerve in the low back that causes radiating pain down into the buttock area and sometimes all the way down the leg. And so it could be that your Parkinson's disease impacts your posture or your your stiffness around the spine, and that causes changes in the the layout, of the bones in your lower back, and makes things shift slightly and causes that pinched nerve. So yes, the Parkinson's can contribute. However, sciatica is just so incredibly common in the general population. So to be able to tell you with any certainty whether your Parkinson's caused it or not on an individual basis is probably impossible. Unless you can clearly say, my sciatica only hurts when I'm off my meds, and when I'm on my meds, it bothers me. Like if you can make that kind of correlation, then it's clear, that they're connected, but otherwise it's really hard to say. Okay, so let's talk about your conundrum, because I think this is probably what you're experiencing. So dystonic pain is the third most common type of pain in PD, according to surveys. I would argue that it's actually, at least in my experience, probably a little more common than neuropathic pain, but the surveys say that it's third. So dystonia, as I said, is an involuntary muscle spasm or contraction, and it can be quite painful. And in PD, probably the most common site is in the foot. The toes may curl, the foot may turn in, but any body part can be affected. It can be any body part. And it's most likely to occur when the dopamine medications wear off. So it's most likely to occur at night or in the early morning hours when you don't have medications working at their finest. When medications wear off, you can get painful off dystonia, and it can be quite uncomfortable. So also when medications wear off, some people experience what we call non-motor off symptoms that can include a variety of unpleasant emotional sensations like anxiety, panic, claustrophobia, etc. And so you might be getting a kind of a combination of off dystonia, which is why everything feels tight and stiff and uncomfortable, and then also claustrophobia might be a little bit of a non-motor off as well. That may be what's happening. That's my best guess, not knowing all the details of your medication and your history, but just best guess. What to do about it? Well, the good news is that we can often optimize Parkinson's disease medications to minimize your experience of the wearing. And there are some wonderful, very long-acting medications that are great for this painful off dystonia. And so first we try to optimize the PD medications. If that doesn't work, there are medications that are not specifically PD medications, they're just dystonia medications, because you can get dystonia even if you don't have PD, and there's separate medications that are just for dystonia. And so if we fail to solve this problem by just optimizing your PD medications, we can try a dystonia medication. And if that doesn't work, then we can get a little bit more aggressive. So if it's just one body part, like foot, we can use botulinum toxin injections to relax the muscles and prevent the dystonia. Or if it's a much bigger body part, if it's all over and we can't find everywhere, we can consider something more aggressive like deep brain stimulation surgery, which is extremely effective for dystonia in Parkinson's disease. And so this is a type of pain that, you know, while it's annoying, we do a pretty good job typically of being able to ultimately figure out a good solution for this one. Any questions about the sign? Yes.
Could you please, go into more detail about optimizing medication?
Yes. So the key is to try to minimize off time. So there are many ways that we can do that. So, and it just depends on the individual, how we approach that. So what we might do for you might be completely different from what we do for the person sitting next to you. But in general, the approach may involve, if you're on a short-acting medication only, like levodopa, it might involve putting those doses closer together and taking more doses around the clock. Or it might involve leaving that alone and folding in another medication that's very long-acting, so that when your levodopa wears off, you're not falling off a really steep cliff down to the bottom where you have nothing, but you have this nice long-acting medication in the background that's controlling that dystonia, so that when your levodopa wears off, hopefully the dystonia is not as bothersome to you because you've got something long-acting in the background. And so it really just sort of depends on the individual, their age, their other medical problems, their other medications, intolerances to prior medications, how we go about picking how we're gonna solve the problem. And again, no two people are alike. And for some people, it's really easy, and for some people, it's really hard. And, you know, for some people, we get it right on the first try, and for other people, it takes like multiple iterations of trying to get it right. So I realize I'm not answering your question, but it's not a simple answer.
Dr. your thoughts on, say, supplements for, to help magnesium for muscle cramping?
Anybody with, anybody with simple muscle cramps ought to try, I think, magnesium first. Because magnesium deficiency is pretty common in the general population, especially if you're someone who hydrates a lot, you drink a lot of water and exercise a lot, the chances of having like just a slight low magnesium level is pretty high. And even just a little magnesium deficiency can contribute to cramps, painful cramps. So you cannot hurt yourself by taking an over-the-counter magnesium supplement if you're following the directions on the bottle. So it's always worth a try. Try it for a few weeks, see if it helps. If you're not someone who likes to take supplements, just eat a banana every day. Bananas are loaded with magnesium. You know, I do have some patients who swear that topical magnesium, the spray, sprayed on their legs at night before bed can be really helpful for leg cramps. You might try that. Always worth a try. But I think if you truly have dystonia, like if your foot looks like that, I don't think you're gonna solve that with magnesium.
One other quick question, thoughts on non-traditional medicines such as, acupuncture or radiation?
And we're gonna get to that in a later slide, but I think that non-pharmacological approaches like acupuncture, dry needling, always worth a try for particularly musculoskeletal pain.
What form of magnesium would you recommend?
I like magnesium oxide, and the brand that I like the best is Magox. It is unfortunately the most expensive. Like, it is not cheap. It's in a white bottle with a label that's like green and blue. It's 400 milligrams of magnesium oxide. That's the one I like the best, and you can take up to 2 a day safely. The worst that's going to happen is it's going to give you diarrhea, and so back off a little bit. That's the one I like. Magox. Magox. It's good for constipation too. So if you're looking for a laxative, 2 of those a day. It's Two birds, one stone. Okay, so I saved central pain for last because it is the least common and it's also the most difficult to talk about. Did anybody here have central pain? Has anybody here experienced central pain? Okay. Would you be brave enough to share your experience? No? Okay, that's great. So central pain is pain that comes from the brain. So this is not a problem with the bones or the joints or even the nerves in the arms or the legs. This is pain that's actually coming from the central nervous system, which is why it's called central pain. And it can often have a very difficult to describe nature. If patients are really struggling to describe what they're experiencing, you know, that's kind of clue number one that we might be dealing with central pain. And often the descriptions can be a little bizarre even. So we often hear words that sound a little neuropathic, like they might describe burning pain or stabbing pain or scalding pain, or they might describe a feeling like bugs are crawling on them or in them. I've had patients describe really bizarre sensations, like it feels like someone has a string of large beads or pearls and they're just running it along the skin. Just really unusual sensations that are just a little bizarre. And it tends to be constant. It doesn't come and go. It's not positional. It's there all the time, unlike musculoskeletal pain, which changes with position and activities. And it is typically very relentless. And it has, you know, for the patient, you know, they tend to be in a lot of distress and can develop almost like an obsessional anxiety around it because it's so unpleasant and, you know, all consuming. So this is not good. And it can be, unfortunately, very difficult to treat. We typically start with neuropathic pain medications. It is often refractory to treatment. And so this really requires a multidisciplinary approach to treatment to try to empower, you know, the patient in as many ways as we can to help them learn to deal with this. Fortunately, this is rare. So management in general of pain. So, you know, I mentioned the multidisciplinary approach is often required, not always. If you have simple, you know, musculoskeletal pain, you may not need a multidisciplinary approach, but you often, you know, do and often benefit from that. A physical therapist to, you know, help you with an exercise program or with dry needling, or a pain specialist or an orthopedist to do injections. So, you know, a psychologist, if you have chronic pain, to help you, you know, from a pain psychology standpoint. So sometimes a multidisciplinary approach is needed and beneficial. There's also been studies that show that empowering patients to have a plan for self-management goes a long way. People who have things they can do at home by themselves to help manage their pain are happier and do better. So, you know, as much as we can empower patients with things that help them at home, like TENS units and, you know, exercise programs and first and second and third line medications they can use at home, you know, the happier they are and the better they do. Medications, again, you know, can help, but we really want to avoid just putting people on chronic medications and sending them out the door. We want to try to find a better solution than just take these pills every day for the rest of your life. So, you know, medications are important and can be beneficial, but we really want to try to approach this from all angles so that medications are not the be all and end all. Non-pharmacologic approaches, so exercise can be helpful in certain situations. Hydrotherapy can be very beneficial in certain situations. Massage in certain situations. And remember that it's not just massage therapists who can provide massage. So physical therapists are, some, not all, are trained in therapeutic massage. And so if you're seeing a physical therapist for pain, part of what some of them offer is therapeutic massage. physical therapists, some are also trained in dry needling. So if you're interested in alternative, non-drug pain management strategies, a referral to a good PT is absolutely important. Acupuncture can be quite helpful. And then depending on the nature of your pain, you know, and whether it's related to your Parkinson's disease, deep brain stimulation can sometimes be helpful, like if it's dystonic pain, for example. And then spinal cord stimulation is used in the chronic pain and pain specialist community for a variety of causes of chronic pain. And so seeing a pain specialist and, you know, looking into more advanced options is always, you know, out there as well. And that is really all I plan to talk about. Does anybody have any lingering questions?
So just as, I was gonna set expectations, we probably have about 5 minutes or so, 5 to 7 minutes for questions, before Henrico County kicks us out. So get them all out now, and like Leslie said, we can certainly send a presentation, we have the recording of the event, but I just wanted to set expectations for Q&A.
Yeah, so, the whole cannabinoid system is very much tied into, you know, the pain experience. And so it absolutely makes sense that, you know, using some sort of marijuana derivative or marijuana might be helpful for dealing with chronic pain. And it is legal in Virginia. And, you know, I personally am not opposed. So, you know, I think if you have explored some of the more traditional avenues and you've talked it through with your personal physician and they're not opposed because they don't have any unique concerns to you specifically about that, I don't see why it wouldn't be worth exploring. It has not been studied specifically in Parkinson's disease for pain management. There's no data behind that, but it's coming, I'm sure. It's just a matter of time. Yeah, so again, no data in Parkinson's disease specifically. Marijuana for sleeping was the question, but anecdotally, I can tell you in my clinic, probably 30% of my patients are taking some form of it for sleep. Not because I'm telling them to do it, but because they're just doing it and then they tell me that they're doing it. Or they don't tell me and I run them through the database and I'm like, what is raspberry gusher? And they're like, oh, that's my gummy that I take at night to sleep with the THC. And I'm like, oh, I didn't know. So lots of people are doing that with success.
Does it work? Does it help?
Yes.
You can sleep
Yes.
6-7 hours?
Yes. The things I'm told anecdotally from my patients who are using it, I have a lot of people who use it for sleep. I have a lot of people who use it for anxiety. I have some people who use it for pain. I have some people who feel that it helps with abnormal involuntary movements like tremor and dyskinesia. Those are the main things that I hear people using it for. Again, there's not good data from clinical trials. So this is people going way off on their own and just doing this and then coming back and saying, hey, this works great.
Where do you,
So take that for what it's worth.
where do you go to, I mean, because you hear so much stuff that you get that could be laced with,
Right, no, don't buy it on the street. Don't do that. So if you want to do this safely, go to Google and put in Virginia medical cannabis. And go to the state board's website for the medical cannabis program. There's a list of all the practitioners in the state of Virginia who are approved by the board to issue a certificate. Many of them do telehealth, so you don't even have to leave your house to have a visit with them. Schedule a visit. If you have a diagnosis of Parkinson's disease, that is on the list of diagnoses that qualify you for a card, no questions asked. So it will be a 10-minute visit where they will say, you have Parkinson's disease? Oh, okay. What do you want to get out of this? Oh, okay. And they will give you a card. Once you get the card, you take that card to the dispensaries, which are all over town, Greenleaf. There's a board certified pharmacist in those dispensaries. You can talk to the pharmacist about what you're hoping to accomplish, and they can help match you to a product.
And I'm sure, your Medicare doesn't cover.
No, this is always, no, that's a good question. That's actually a really good question. This is not gonna be covered by any kind of insurance. It's an out-of-pocket expense, and it is not cheap. Very expensive. So I don't know exactly how much, because I have not explored this myself, but I have had patients tell me that a small container of gummies, just like 12 gummies is like upwards of, $60 to $90. So it is not cheap. But they cut them up and, I'm sorry, I didn't hear the question. Yes, they sell all of the products, gummies, like oils, the actual leaves for smoking. I just recommend people don't smoke it. It's bad for your lungs. Eat it, don't smoke it. You can maybe just give me your email and I'll email them to you.
Leslie, I can,
Or
if you send them to me, I can send them to you.
Oh, even
Yeah,
easier.
if that
Okay,
works.
that's
Yeah.
fine.
Thank you, Dr. Cloud. Well, we didn't think the conversation was gonna go in that avenue, but it did. Thank you so much for being here. Please visit our friends at AbbVie, talk a little bit about I guess also legal therapeutics. But thank you for being here. We appreciate it.